So blood disorders can seem pretty scary, but hopefully in this PowerPoint we can kind of break down what makes these different, and so you can kind of know what's going to be kind of imperative and what is your role as the nurse for these patients. So there are many blood disorders, but luckily for this class, you only need to focus on three. We're going to talk about iron deficient anemia, aplastic anemia, and polycythemia vera. You should also be familiar just in general, what does anemia look like? What does not having enough red blood cells or hemoglobin look like? And so knowing those general symptoms is very, very helpful as well. But for this PowerPoint, we're just going to focus as a whole on iron deficient anemia, aplastic anemia, and polycythemia vera. So let's start with iron deficient anemia. So in the name itself, it already kind of tells you what the problem is. There is not enough iron. My blood levels are low in hemoglobin and iron. I'm going to have a low iron level and a low ferritin level. So I see commonly, like at clinical and just students in general, when I ask them about these labs, they usually focus on the red blood cells, and we definitely, they're going to be low, and we don't want them to be low. But keep in mind the lab that we keep the most eye on is the hemoglobin, because the hemoglobin, again, that's the red blood cells that are carrying oxygen. So this is going to tell you, really how severe is their anemia. Are they to the point where they do not have a lot of red blood cells that can actually carry oxygen to your cells? Because that's really one of the main jobs of the red blood cells. So how much hemoglobin do I have? The blood levels are going to be, like I mentioned, low in hemoglobin and low in iron. So think low in oxygen carrying abilities, low in iron. That's my problem. Think with all anemias that there's something missing. There's a part of the puzzle piece missing. And so red blood cells can't be produced or made the way that they're supposed to. So, like kind of like if you were at home and you were trying to make a recipe and you were missing one ingredient, that's kind of what anemia is like. You can't make your recipe without this one crucial ingredient, and that's what iron deficient anemia is they don't have iron, so they cannot make the red blood cells like they want to. Anyway, enough with the analogies. So, what do you call it? Even though the blood levels are low in hemoglobin and iron, they're actually going to be increased in what's called the total iron binding capacity. And effectively, what this is it's the pretty much think of it like parking spots for the iron. Like, in a patient that has a normal amount of iron, there's going to not be a very high level of TIBC because these are parking spaces. If I have a lot of iron in my system, there a lot of the iron is going to be parked in these parking spaces. But if I'm low in iron, I'm going to have a high amount of capacity or high amount of places that iron can park in my body because there's not a lot of iron around. In other words, kind of think of it kind of like right now, that like, it's a lot easier to find a parking space right now because there's not as many people out and about doing things. It's the same thing when there's not a lot of iron around, there's a lot more space for iron to attach to in the body because there's just not a lot of iron around. People aren't using those spaces out in public, and iron isn't using those spaces in your body because they're low on iron. So for to treat this patient, they are missing iron, so we're going to give them iron. So they need some teaching about that iron. So we always want to tell them to take it on an empty stomach with some sort of vitamin C like orange juice. I always like to let patients know that it can cause constipation, so just they may need a stool softener, they may need to increase some of their fluid intake or fiber intake to help with that. Their flu sorry, help with the constipation. Sorry, my cat's being needy and wanting to be petted. Um, so also another thing is that iron turns stool black. And so a lot of times this can be very concerning because usually when stool turns black, it means you're bleeding. So we usually like to tell patients, hey, your stool's going to turn black. This is expected. You don't need to necessarily report it. If the doctor asks, you can tell them about it, but it's not something you need to call 911 or come to the hospital like an emergency. It's expected that their stool's going to turn black. And then these patients, even if we give them back their iron, which is what they're missing, even if we run out to the store and get that ingredient we needed for our recipe, it may be like a little bit too late in this. So this patient may still need blood products. They may need, what do you call them? We call them some replacement. So kind of think of it like that recipe. Even if you go back out and get whatever you're missing for your recipe, all the other ingredients might have, gone stale, and you might kind of have to start fresh. You need some more to help support you along the way. You might have to get all new ingredients. So what we do here sometimes is replace blood in patients, and it has to be that their hemoglobin gets low enough, and that's going to be a doctor decision. But usually, a normal what do you call it, hemoglobin level for most people, it's a little different in gender, but usually about 12 to 14 is normal. So when it starts to get low, they may need some blood replacement to kind of help them so that they're getting enough oxygen to their tissues. Then there's aplastic anemia. And aplastic anemia, think of a patient that's like a fragile doll. Everything is low, and I need to protect this patient because they are going to be at very high risk for a lot of problems. So, a patient with aplastic anemia has low platelets, low hemoglobin, and low white blood cells. And that translates to that they cannot clot, they cannot get oxygen to their tissues, and they cannot fight infection. So this patient's going to have a lot of risk. I want to protect them from bleeding and infection because, again, they do not have the supplies they need to protect themselves. And then I possibly may need to replace what they're missing. If they're really low on their hemoglobin or really low on their platelets, I might replace those. But at the end of the day, what this patient needs is a bone marrow transplant. And along the way, while they're waiting for that, because again, the problem is that they don't have a supply. There's something wrong with their bone marrow that makes all of these cells that's not making them the way that they need to. So along the way, they're a fragile doll. I need to teach them a lot about how to prevent infection. I need to teach them bleeding precautions, how to prevent themselves from injury, to avoid contact sports, which anyway, you shouldn't be around a bunch of people if you're high risk for infection. But this patient may end up on what we call neutropenic precautions, where I have to put them in protective isolation. In other words, I need to wear, and of course, right now everyone's wearing a mask, but I need to wear a mask to protect this patient because they're at risk of getting an infection from me. So I'm trying to do everything I can to try to prevent them from getting an infection. They're going to have no fresh fruits, no fresh flowers in their room, and they shouldn't be around anyone who's sick. Last but not least, there is polycythemia vera. And you're going to see that there's two types. There's primary and secondary. We really focus on primary polycythemia vera in this class because that's going to be the type that, secondary, like it can go away once you treat the underlying problem. Primary, we need to treat the problem of polycythemia vera itself. So the problem here, unlike aplastic where they didn't have enough cells, they actually have too many cells in polycythemia vera. The blood is thick and it's full of cells. There's too many platelets, too many hemoglobin, and too many white blood cells. And you may think like, hey, that's great, right? But there's always too much of a good thing. They can also have elevated uric acid because pretty much the breakdown product of all these blood cells is uric acid. And we're going to talk about later in the semester about gout, which is too much uric acid. But in other words, they can start to have pain and accumulation of what do you call it, this uric acid in their joints. And so it can definitely cause them some discomfort. This patient has too many cells. So, like, compared to most of the patients that we've talked about so far that are probably going to be pale, they have that low hemoglobin. This patient has too much hemoglobin. So they get like what we call plethora. They get really red. Their hands can get red. And they can actually get really itchy skin because they have so many cells that the body is trying to like excrete all of these waste from all these extra cells through your skin. It can cause their skin to get really itchy. So overall here, if I have too much of all of these cells, my goal is going to be to have less cells. And so I can do that by phlebotomy, which is literally like, think about kind of like giving a blood transfusion. We actually drain blood from this patient. We're not giving it to anyone else, but we're draining it from them because they have too many cells. We also can give bone marrow suppressants, or that patient for aplastic anemia, they needed a bone marrow transplant. This is the patient that has their bone marrow is on overdrive, producing too much. So we need to suppress it or say, hey, buddy, you need to slow your roll down a little bit. We also want to prevent complications in this patient. So they have a high risk of blood clots, so they're going to be on aspirin. And then, of course, like I mentioned, we want to decrease the symptoms, that pain that they're having because of the uric acid buildup. We may give them anti-gout medications. We should encourage this patient to drink not excess, but extra fluids because remember, pretty much it's not that they're full of fluid, they're full of cells. So imagine in your blood, if there was a whole lot of cells, not a lot of water, it's going to get really thick and there's a much higher chance that they're going to clot. So we want to encourage fluids in this patient and also watch for complications. Look for signs of blood clots because remember, blood clots can be in the leg, they can be in the what do you call it, in the heart, they can have a stroke. There's so many different places you can get a blood clot. But we're going to be checking their peripheral neurovascular really closely and looking for those signs that they're getting a blood clot. So that wasn't that bad, right? Not too bad. Thinking about the three types of anemia, when you just try to break them down. So always be thinking about these disorders. What's really the problem? What's going on with their cells? Do they have too many? Not enough? What are they missing? And how are we going to help this patient? Like what are they missing? So therefore, what do we need to give them? And that's a lot of what anemia is. It's getting all of the pieces of the recipe of that you need for a red blood cell, so that you can make red blood cells and therefore, oxygenate your body. Or like in polycythemia vera, it's that you have too much and it's getting rid of that excess. So hopefully this helped. I'll talk to y'all later.